Yes, my name is Inès. I am really glad to be talking today for this shared session with the ESICM and the e-sfar. I would like to thank the Comité Scientifique de e-sfar for the invitation, and I am really glad to talk right after two excellent speakers and experts in sepsis. So when I first got the information of the title of the presentation, my first thought was, okay, this is going to be really short, because basically in my mind, source control is just going really fast to the OR and really fast to surgery. But then I got some thinking about it, and I digged in the literature, and well, I found that the message might be a bit more complex than that. So I decided to divide my presentation in two parts. The first part would be the classical source control with surgery, you know, the definition, timing, and adequacy of source control. We'll talk about some gaps in evidence in the literature. And then the second part would go a bit further beyond the source control, mention just local antibiotic therapy and what to do when source is not removable. So very first question, why does source matter itself? These are the results of a study that we performed when I was back in Marseille with Professor Léon. We took a look at our national database called PMSI in French. And we included all the patients with a septic shock code. And what we found is here that just the fact of knowing the source of infection in your patients is associated with higher survival. This might be because of two things. When you know where the source is, you can control it. And then when you know it as well, you can adapt your antibiotics, and specifically probabilistic antibiotics. All sources are not equal either. These are the results of a study. This is nationwide as well, but US-based, reporting the data from 2.5 million patients who had a sepsis-related death. And what you can see here is that most of the deaths are associated with pneumonia compared to abdominal and genitourinary. This is basically because pneumonia has a higher incidence than the other two infections, but also because probably that source control is more difficult to perform in pneumonia compared to the other two. So what is source control? What do we mean by source control in practice? There are mainly four strategies, four pillars to source control. The first one would be debridement. I'm sorry, the T is missing there. The second one would be drainage of purulent collections. The third one would be the removal of any infected device. And then the last one would be diversion or decompression, diversion being the way to stop contamination by diverting the patient physiology. In this review by Jan de Veel, who is currently the president of the ESICM, by the way, they report all the possibilities and all the options for source control according to organ systems, from brain abscess that can be drained to endocarditis that can be debrided, to intra-abdominal infection and skin and soft tissue infections as well. But one of the major messages here, and the take-home message that we can all take home basically, is that source control is not just one procedure, one time. It has to be reassessed continuously, and this is an ongoing procedure that needs to be personalized to your patient, and you have to check every day whether your source control is adequate or not. And this must be a multidisciplinary management, since you have to have your surgeons involved in source control of your patients in the ICU. So why does it matter? Because basically delay kills. What you can see here on the left side of the slide is a study published in JAMA Surgery reporting data for more than 4,000 patients with sepsis and septic shock. And you can see a cutoff at 6 hours, showing that when source control is performed before this cutoff, it is associated with lower 90-day mortality rates. To confirm this data is the study by Professor Roger, which shows in 200 patients that time from imaging to surgery is associated with higher risk of death. Each hour is associated with higher risk of death. So delay kills, and you must go to the OR fast. Probably the adequacy of source control matters as well. These are the results of the Obsess study, which is an international study including patients from 300 ICU worldwide. And what they report in more than 2,000 patients undergoing surgery for source control is that only 53% of them had a successful procedure for the source control. And whether you define failure of source control by persistent signs of inflammation or by the need of an additional intervention, both definitions are associated with mortality in critically ill patients. How do you define that source control is adequate? This study looked at 300 patients, and what they show is that looking at your patient helps you better than any biomarker. So meaning that worsening organ failures, shown here by a worsening SOFA score, or going from sepsis to septic shock, is associated with inadequacy of source control. So you must look at your patient every day, reassess him or her, and provide adequate source control. Just one word about this new trend in surgical source control for intra-abdominal infection. So there have been lately a lot of publication on what is source control. So source control is supposed to reduce the bacterial inoculum, but there are some hypotheses that report that source control should also reduce the inflammation. So there is this study that is ongoing, which is called the COOL trial, that compares open abdomen to closed abdomen for intra-abdominal infection. And their hypothesis is that putting a vacuum on the patient with negative pressure will remove all the biomarkers of inflammation. And going for a second and third look can also remove all the inflammation in intra-abdominal infection. And their hypothesis is that this would lead to better outcomes. So this is still ongoing. I don't have the results for this. Another trend lately is the use of minimally invasive source control. I will not go back to ERCP for acute cholangitis. This has shown evidence of being associated with a higher survival. And lately, more and more data have shown that the earlier the better, as for any source control. But there are now solutions for endoscopic source control, from endoscopic suture and clips for early perforation with limited contamination, to vacuum for fistulas, or to drainage and necrosectomy. I just wanted also to say a word for robotic surgery, and this approach has been implemented in emergency surgery for intra-abdominal infections, such as cholecystitis, for example, and this is more and more used nowadays. We, as anesthesiologists and intensivists have to be careful on what patient can undergo robotic surgery. This would be basically the same patients that would be allowed to undergo laparoscopy. They have to be hemodynamically stable to go to robotic surgery. So we've talked a lot about intra-abdominal infection. Let's think a bit outside of the abdominal box and talk about catheter-related bloodstream infections. These are one of the most challenging infections in the ICU, and we have more than 15% of our patients that have catheter-related bloodstream infections. It's quite frequent, but still literature is lacking, as is reported here in this scoping review that has been published lately in 2025. They report data from 77 studies, and only one RCT could be included. Among them, only 16 mention had a focus on source control. And what you can see here is that there is high heterogeneity on what is source control in catheter-related bloodstream infections, from time zero, which can be defined as blood culture sampling, or randomization, or the onset of infection and sepsis, to what is exactly the source control, from catheter removal to, well, not clearly defined. Also, on the timing of source control, from 12 hours to 24 to 48. So there's a lot of heterogeneity, and also heterogeneity in the definition of what is catheter-related bloodstream infection. You know that there are two types of definition in the literature. The first one would be microbiologically confirmed, either by the culture of the catheter or differential blood cultures. And the second one would be just surveillance-based, meaning that you suspect a catheter-related infection just when you have a blood culture which is positive. And of course, in microbiologically confirmed catheter-related bloodstream infections, you have to remove the catheter, and the earlier the better, as shown here in the study. But maybe in other types of infection, that just the surveillance-based, the systematic removal of the catheter can be associated with the risk of misclassification, meaning that, okay, I have a blood culture which is positive, let's remove the catheter and I'm done. This is good, I've done my source control. So this can be misleading because we should always look for another source to control. And this is the idea of the evolution of the guidelines for candidemia, for example, here. And what we can see that in 2009, the guidelines said you should always remove the catheter. In 2016, I'm sorry, it's not showing off. In 2016, it was remove only if catheter is the presumed source, and in 2019, you just should do an adequate source control. So just a word about also soft tissue infections. Time is essence again. In both studies, on the left is a French study, on the right is a meta-analysis. What is shown is that surgery performed before 6 to 14 hours, here 12 hours, is always associated with higher survival. Just a word about what can we do when source control is a challenge. For example, for pneumonia, how do you perform source control in difficult situations? We know that antibiotics administered intravenously are of low penetration in the lungs. And when we want to have high concentration in the lungs, we have to go high in our concentration, in our systemic concentration, meaning that we are at risk of toxicity. So one of the solutions for that is the use of nebulized antibiotics, which can provide high local concentration and low systemic toxicity. Of course, this is difficult to perform because it depends on ventilator settings, on the nebulizer type, on its position, on the drug, on how you manage to have a droplet of good size. But still, it has an impact on the rate of microbiological eradication. It has shown to be associated with higher microbiological eradication, but it has no impact on clinical recovery and survival outcomes. So it has probably to be used for MDR pathogens and difficult to treat pathogens. Now, just a word about what to do when source control is literally impossible, when you cannot, for example, remove the device. This is the case for a cardiac implantable electronic device and left ventricular assist device. They are usually in patients who are really fragile, and the solution for that would be a salvage option of suppressive antibiotic therapy, which is a long-term antibiotic therapy. So I have put that in big. This should be always a salvage option. You always have to consider the removal of the device. So to finish, my take-home message would be this one: please identify the source, even if it's a bloodstream infection. Early and adequate source control saves lives, obviously. Minimally invasive strategies are to be used in the ICU, and suppressive antibiotic therapy can be used as salvage when source control is not possible. Thank you very much for your attention.